Hi, this is Kim, and this is a review of the important but sometimes confusing concepts in the endocrine lecture. So make sure you have your handouts from the endocrine unit in front of you, including the comparison of type 1 and type 2 diabetes, the insulin medications, the protocols for hypoglycemia and DKA, and then your grids for SIADH and DI, for Cushing's and adrenal insufficiency, and for thyroid, hypothyroid, hyperthyroid, and your hypoparathyroid and hyperparathyroid. So let's first talk about diabetes. And as you know, type 1 diabetes requires insulin administration because the body is no longer using insulin, whereas type 2 starts out as more of a cellular insensitivity to insulin, meaning the glucose can't move from the bloodstream into the cell very well. And sometimes that can be um, managed with diet and exercise to help make those cells more sensitive. But if not, they usually start on oral medications first and then go to your insulins. So while we're talking about that, let's look at our table that compares insulins. Um, You'll find different peaks and onsets for various types of insulins, but I thought putting the table together this way is kind of an easy to remember the basic common prototypes and the important onset times and peak times that you need to know. So be sure to know the difference between rapid acting, short acting, intermediate acting, and long acting insulins. For example, Humalog and Novolog, your Lispro and your Aspart are rapid acting. Those onset within 15 minutes. So that's why it's so important when you're administering Humalog, if you are giving it before a meal, that you're not giving it earlier than within 15 minutes of the meal. And that does peak in 30 to 90 minutes, so they definitely need to be eating within that time. But it only lasts 3 to 5 hours. It does not last very long. In fact, the recent recommendations for managing diabetes usually include either an intermediate acting insulin, such as Humulin N or NPH, because that does last about 8 hours. So that's usually given before breakfast and supper. And then along with that, they usually prescribe a Humalog or Novolog, a rapid acting, insulin, just to cover blood sugars that are still up above 150 despite that intermediate acting. You might also see the same kind of treatment plan with long-acting insulins, such as Lantus or Levemir. And as you know, those last for 24 hours. They don't really peak, but then they would cover the patient's blood sugar using these rapid-acting or short-acting insulins. Now, the difference between rapid-acting and short-acting, for example, Humulin R, regular insulin, is short-acting. That takes about 30 minutes before it onsets, 30 to 60 minutes. So you have up to 30 minutes before meals to administer that if you are giving it before a meal. And that does peak in about 1 to 2 hours, and it lasts a little bit longer than your rapid-acting. So for rapid and short-acting, the onset times are what are crucial to remember because you need to time those with meals, as I explained. However, with your intermediate acting insulins, those are a longer onset, 1 to 3 hours. So as long as the patient is eating, they're not ill where they're not eating, it's not as important to time those with the time that they're actually eating, as long as it's within 1 to 3 hours. But you're concerned about when they peak, because they peak in about 8 hours. So if you consider you're giving insulin usually about 7 a.m. or so, so if it's peaking in 8 hours, calculate that in your brain. That's about 3 p.m. and they're not eating at that time. And so you want to monitor your patients in the mid-afternoon for signs of hypoglycemia. So let's talk about those signs. I know back in farm you learned the saying, cold and clammy need some candy. That can be a sign. Most frequently you're going to see maybe some mental status changes, some confusion, irritability, diaphoresis, they're sweating, might be shaky and hungry. So at that point, if you haven't already, you want to check their blood sugar. And let's check this is a sample hypoglycemia protocol that's out on Blackboard. Um, and so if you're noticing those type of symptoms and get a blood sugar, or you're just getting the scheduled blood sugars that are before meals and before bedtime generally, and you find their blood sugar to be less than 70, 70 is the magic number. Um, and then from there, this protocol distinguishes between severe hypoglycemia and mild hypoglycemia. With mild hypoglycemia, their blood sugar is less than 70. They may or may not have the symptoms that we talked about, but they are able to eat. That's the big thing. They can eat, they can swallow. So you can immediately, based on this protocol, you don't have to call the physician if this protocol is in place. You can immediately administer 4 ounces of juice. Just juice, don't add sugar to it. That's kind of an old-fashioned way of doing things, and not effective because that actually causes spikes in their blood sugar. Or 8 ounces of milk are generally what's given. And then from there, you're going to recheck their blood sugar in about 15 minutes. If it's still below 70, you're going to give this again, the 15 grams of carbs in juice or milk. From there, you're going to recheck their blood sugar every 30 minutes, twice, um, until they're definitely up above 70. If the blood sugar remains below 70, obviously you're going to call the physician. You're going to be watching their blood sugars carefully over the next day or so, and you are going to report this event to the physician prior to the next scheduled insulin dose. However, if they are so hypoglycemic that they are not able to eat or swallow, you're going to be giving IV dextrose, D50, 50 milliliters of it. You can give glucagon 1 milligram IM as another option too. After that, basically, the protocol is pretty similar. So always, for any patient that's diabetic that's receiving insulin, you're always going to be monitoring for those symptoms of hypoglycemia and then reacting appropriately. As you know, if it's not treated appropriately, they have the life-threatening complication of a coma that they may not be able to recover from. So, back to our insulin table. We know our symptoms of hypoglycemia. Also know our oral agents. Know the prototypes and the basic actions. Which one actually increase insulin production, meaning you're going to want to check blood sugars before giving that and making sure they're eating before giving it. Which ones require the liver, affect the liver in terms of glucose production, and therefore if the patient has severe liver disease, you'd be monitoring that very carefully. You'd be monitoring them closely for jaundice. And which ones may cause GI upset, and that's precose especially can cause GI upset. So do know these insulins and these medications. Back to our table here. Let's now talk about the other end of the continuum, which is hyperglycemia. As you know, with type 1 diabetes, patients are at risk for DKA because when the body can't use that sugar in the blood, it starts breaking down fats, which create ketones. Ketones are acidic. That moves them into acidosis. That's why they have the ketones. They have the fruity breath because of the ketones, and then they start having symptoms of acidosis. And as you remember, with acidosis, metabolic acidosis, patients will develop Kussmaul respirations, those rapid, deep respirations in an attempt to blow off carbon dioxide and decrease the acid level in their blood. HHS also is hyperglycemia, but this is occurring in patients with type 2 diabetes, meaning their body is still producing enough insulin that they're not going to create ketones, so they're not going to become acidotic, but the problem is they become, their blood sugar becomes so high because they're not having those general symptoms of Kussmaul respirations and fruity breath, and if they're not getting their AccuChecks checked 4 times a day, they can become very, very high, 600, 700, 800 in blood sugars. So their problem becomes severe dehydration. And as you remember, as the blood becomes more concentrated, the fluid is going to be pulled out of those cells into the bloodstream, which the kidneys are going to, filter out, causing polyuria. And as they have extensive polyuria, they become even more dehydrated, and now they're at risk for complications of extremely low blood pressure, etc. So let's look at the sample protocol for DKA. Like I said, these are samples from the Mayo system that I just obtained through with my clinicals with students. This is actually a protocol used in a regional facility, meaning the nurses, without having a physician actually present, have this protocol in place, and they can immediately initiate treatment before the physician is there, which, as you know, can be critical in these type situations. So this little grid here I think is kind of interesting as they distinguish between DKA and HH clinically. What do they have previously, type 1 or type 2? What is their current glucose? And as you can see with HHS, it can be very high. People with type 1 diabetes can develop symptoms of DKA with blood sugars as low as 250. What is their pH level? And as we said with DKA, it's going to be very low because of the acidosis. With HHS, it's going to be back in normal range. Large amount of ketones with DKA, maybe a few in HHS, but not significant enough to cause acidosis. And the bicarb, because so much bicarb is being tied up to try to counteract those acid levels, their bicarb is low. And, as we said with HHS, because of the concentration that's occurring in the bloodstream because of the mass amounts of blood sugar, their serum osmolality becomes high. So what do you do? So with DKA, for adults, they're going to be drawing these different labs, doing an AKG, because as you remember, with acidosis, there's cellular buffering going on as compensation. We have the lungs compensating, causing Kussmaul respirations. We also have the cells compensating. As you remember, the cells exchange hydrogen ions for potassium, causing hyperkalemia. So they might arrive being hyperkalemic based on their level of acidosis. So we're going to be monitoring their potassium closely. We're going to be inserting a Foley, monitoring their urine output, and then monitoring their blood glucose at least every hour once the insulin drip starts. But the important thing to remember is you are going to be starting IV fluids before you start the insulin drip, because we need to make sure that the kidneys are getting flushed and working properly before we start the insulin. So you're going to be starting with normal saline. That means 0.9%. However, as we know, if their serum sodium levels are already high, if they're already hypernatremic, they're actually going to start with hypotonic fluids here. However, another key point here is once the glucose is less than 250, the IV fluids need to be changed to D5, normal saline or D5.5, because now think about the fluid movement that's going on as the blood is so concentrated because of the blood sugar, and as that blood sugar is starting to come down from the insulin, we could quickly move into fluid movement shifting into the cells, which can cause cerebral edema, which is a life-threatening complication. So to avoid that, that's why they're adding a hypertonic solution until we get those blood sugar levels down to normal. Otherwise, it seems kind of strange. Why would you be giving dextrose or sugar water to someone that's got a high blood sugar? So fluid rates, they start high, 500 cc's an hour. That means you're going to have to be watching that IV site very closely. You could blow the line. Once their pulse is less than 100 and their urine output is greater than 30, now you're going to decrease the rate to 250. So remember, urine output is generally 30 to 60. So we need to get it back up in that range before we can start our insulin. And think about why we're monitoring the pulse. As I said earlier, with that dehydration that's occurring, their blood pressure is going to drop. As their blood pressure drops, their heart's going to compensate, causing tachycardia, putting them at risk for arrhythmias. So a quick way to monitor that level of dehydration is to be monitoring their pulse. So now let's look at page 2. And as page 2 explains, if the patient is severely acidotic, meaning their pH is less than 7, you're going to be adding bicarb to their normal saline. And remember, bicarb, just like the kidneys are saving bicarb, this is a quick way to help move them over back into normal pH range, because body just isn't going to be able to compensate with the lungs and the kidneys quick enough to get them out of acidosis. So we're helping the body out by actually giving them some bicarb. We're going to be watching the potassium very carefully, especially once we start the insulin. So if they're already, this is still normal range, 4.5 to 5, but if they're already at that level, they want to start some potassium initially before you even start the insulin drip. And then once we start the insulin drip, we're going to be watching that potassium very carefully. As one student mentioned, it's like the insulin is like a train that's moving the blood sugar from the bloodstream into the body, and the potassium is a hitchhiker going along for the ride, goes into the cell. So we need to be watching that potassium level very carefully. But the really important thing to remember here, and that's why it's in bold, is be sure to start that fluid resuscitation and the potassium before starting the IV drip. So you're going to be giving IV regular insulin. You're going to be giving a 10-unit bolus, and then you're going to be initiating an insulin drip based on how many units an hour, based on what their blood sugar is. And like we read earlier, you're going to be monitoring that blood sugar every hour and adjusting this insulin drip as needed. Patient does need to be NPO except for water while they're on this drip, because we're watching that glucose very carefully. And then because this was a regional site, they indicate that a transfer can be undertaken at this point if needed. So the HHS protocol is very similar. I'm not going to spend time talking about it, but that one has just a little bit different drip rate based on their glucose values. So do know the order of implementation, the sequence of the order of your implementation for those things. Okay, now let's talk about another potential problem, which is also hyperglycemia, not to the extent where they're DKA or HHS, but Dawn phenomenon means that, and this is something you'd see typically in a long-term care facility, every morning when you're getting their blood sugar, you're noticing that they're high, that they're always high. You're always using sliding scale to bring down that blood sugar level. Both of these situations, Dawn phenomenon and Somogyi effect, can be causing that high morning blood sugar. The difference is with Dawn phenomenon, in the evening, when they go to bed, they just continue to get higher and higher and higher blood sugar, either because they're not getting enough insulin or medication before they go to bed, or, as we all know, your cortisol is being released at night, and as you remember, cortisol causes increased blood sugar, and that's what's causing them to be high in the morning. So patients with Dawn phenomenon actually need more insulin or medication at night before they go to sleep. On the other hand, patients with Somogyi effect start out with a normal blood sugar, but because of their medications, typically insulin, they actually become hypoglycemic at about 2 a.m. or so, middle of the night, and the body has a rebound effect. It compensates and creates more blood sugar via the liver, for example, and then by morning they are back up high because of that rebound effect. So these patients actually need less blood sugar, less insulin at bedtime, so that their blood sugar doesn't drop so much in the middle of the night. So what do you need to know as a nurse because of this? You're going to be seeing high blood sugars in the morning. Typically, your AccuCheck protocols orders are before meals, at bedtime, and PRN, which means you can get a blood sugar at any time if you're noticing symptoms. So these people need to be awakened at 2 a.m. just once or twice if you're not sure, but just see what their blood sugar is at 2 a.m. If it's Somogyi effect, their blood sugar is going to be low. If it's Dawn phenomenon, their blood sugar is already going to be high. Then you can call the physician in the morning, later, once you get a hold of them, or use the fax system or whatever is being used, and let them know that what their blood sugars have been consistently every morning, and that you got a PRN AccuCheck at 2 a.m. and whether it was low or high, and then you can request orders either for more insulin in the evening before they go to sleep, or less insulin if it's Somogyi effect. Okay, terms of complications, chronic complications, obviously the closer we can keep their blood sugar down below 150, the less likely they are to develop these complications. So do know the symptoms that go along with retinopathy, obviously change in vision. Neuropathy is pain, neuropathic type pain, and as we mentioned, gabapentin and those anti-seizure type medications tend to work best on neuropathic type pain. Nephropathy, kidneys, we're going to be monitoring their creatinine levels, their BUN levels, and their estimated glomerular filtration rate. PAD, peripheral arterial disease, they're going to have pain in their legs, especially on walking. As you remember, that's called intermittent claudication. And because of the decreased circulation and the decreased sensation, these patients are set up for a lot of foot issues. They can injure their feet and not feel it and then end up with an infection. Infections don't heal very well because of the high blood sugar, and then you're just going down the path that can lead to amputations ranging from toes to feet to below the knee, above the knee amputations. So be sure to check your diabetic patient's feet every day for any signs of injury or infection. And do know, how to teach patients how to do their own AccuChecks, how to administer insulin, the lifestyle changes in terms of diet and exercise, what will happen with these chronic complications if it's not controlled, and then good foot care. And then do know how to teach them about managing illness. A lot of people think, oh, if I'm ill, I'm not eating, I don't need to take my insulin, but actually, because of the stress response, they might actually need more insulin. So, at the very least, they need to be checking their blood sugars very closely when they're ill and using those sliding scale orders that they have. Okay, so that's the basics on diabetes. Now let's talk about SIADH and DI. I find these grids very helpful because if you can, during the test, remember one side of the grid, but maybe not remember so much about the other side, you can usually reverse whatever's going on and come up with the right answer. So SIADH is too much ADH. As you remember, ADH causes the body to save water. So as you're saving water, your blood becomes more dilute and your urine becomes more concentrated. So as a result, the lab values that you're going to see, as the blood becomes more dilute, you're going to see lower serum osmolarity and probably lower sodium levels. Not because the sodium level is changing, but just because of the dilution effect. As you're saving fluid, though, your urine is going to become more concentrated. They're going to have decreased urine output. So their urine-specific gravity is going to be very high, more concentrated. So as you think through those things, then you come up with the common symptoms. As you're saving fluid, your blood pressure is going to be increased. You might have some edema, weight gain. And so you want to make sure in your plan of care, in your care plan, that you're monitoring those daily weights and I's and O's, etc. And do know who's at risk. If you're taking care of anybody that's had any kind of head trauma, you're going to be on the lookout for SIADH, and your first sign is going to be that decreased urine output. Small cell lung cancer, the actual cancer cells produce ADH, so those patients are at risk for ADH. DI, on the other hand, is not enough ADH. This also occurs with brain tumors, head injury, and lithium can cause it. With DI, your body doesn't have enough ADH, so your patient is losing all that fluid. So their urine becomes very dilute, and in fact, that's one of the first signs you'll notice as a nurse is the extremely high urine output. It can be 5 to 20 liters of urine output. But as they're losing all that fluid, their blood becomes very concentrated. So they'll have a very low urine-specific gravity because the urine is so dilute, but the blood is more concentrated, so their serum osmolality and serum sodium levels will be high. So tie the common symptoms that you'll see, like we talked about with DI. Now they're at risk for low blood pressure because of the fluid loss. They're at risk for losing weight, etc. So tie your symptoms back to that. actually replacing ADH. But consider this as a continuum. If they start out with DI and you're administering DDAVP and they get too much DDAVP, they could very well move over into symptoms of SIADH. So you want to make sure you're teaching your patients, if they're taking that at home, to monitor for signs of too much replacement and when they need to call their healthcare provider about that. Okay, now let's talk about Cushing's and adrenal insufficiency. Now the difference with these conditions is with these they have too much corticosteroids with Cushing's. And remember, corticosteroids include your mineral corticoids, which is your aldosterone. And as you remember, aldosterone saves salt, and as it saves salt, it gets rid of potassium. So in addition to aldosterone, they'll also have too much cortisol. And as you remember, cortisol is involved in the stress response and causes increased blood sugar, and it can also affect the immune system and bones as well. So tie your symptoms into symptoms of too much aldosterone and too much cortisol. So hyperglycemia, hypernatremia, hypokalemia, and as a result, how does that affect your blood pressure as you're saving salt, saving fluid? There's a nice picture out on Blackboard if you're a picture person. The common manifestations of Cushing's also are the moon face, the abdominal striae, the buffalo hump that they call, I hate that word, the risk for osteoporosis because of that cortisol effect on the protein catabolism on the bone. Puts them at risk for osteoporosis and fractures. So think in terms of, as a nurse, what symptoms would you notice with a patient that has not yet been diagnosed with Cushing's, but could be developing it? And that commonly happens in people that are on prednisone. And as we talked about, this would include people with COPD that take prednisone daily to help with breathing, people with rheumatoid arthritis that need prednisone to help with that inflammatory process, people with inflammatory bowel disease. Anybody that's taking prednisone on a regular basis is at risk for Cushing's. So as a nurse, you want to be monitoring for those signs of the Cushing's syndrome. There's also a Cushing disease, and that's caused by a tumor that causes the secretion of more ACTH. But the Cushing syndrome is often more common. Do know what these surgeries mean. Transsphenoidal resection of the pituitary. Where is that? Know your post-op interventions for that. Adrenalectomy. Where are your adrenal glands? Where do you anticipate finding a dressing that you're going to be monitoring for hemorrhage? What are some common complications of adrenalectomies as well? Adrenal insufficiency, on the other hand, is opposite. They don't have enough corticosteroids, meaning they don't have enough cortisol, they don't have enough aldosterone. So vice versa, don't have enough aldosterone means their serum sodium will be low, their serum potassium will be high. Cortisol can cause decreased blood sugar. And the major complication with adrenal insufficiency is that Addisonian crisis. And the crisis is a medical emergency because of that lack of aldosterone. They're not saving salt, they're not saving water, which dramatically decreases their blood pressure. And the normal things that we do for people with low blood pressure are give them fluid boluses, which may briefly raise their blood pressure but isn't going to do the trick. These patients need supplements of the corticosteroids. They need the hydrocortisone, for example, to be able to replace that aldosterone, replace the cortisol, and then they can maintain their blood pressure. But patients with just plain old adrenal insufficiency because of Addison's disease will need to be on lifelong replacement therapy. That's your hydrocortisone and your Florinef. But I don't want to neglect saying that this is also a possibility for people who have been on prednisone for long periods of time and then suddenly stop. They're at risk for adrenal insufficiency too, because when you're taking prednisone, you're taking corticosteroids, your body stops just automatically producing its own. So if you stop taking it as a supplement, your body's not producing it on its own, and now you're at risk if you do stop suddenly for Addisonian crisis. So always think in terms of aldosterone and cortisol when you're thinking about these conditions. Okay, and lastly, thyroid. Hyperthyroid has too much thyroid hormone. Remember, the thyroid hormone we're measuring in the blood is T4, T3 and T4, but mostly the T4 is what they're looking at. And if you have too much T4, then your TSH is actually going to be decreased, because your brain is going to be telling your thyroid, hey, we don't need any more thyroid hormone. Other common symptoms you see with hyperthyroidism is goiter, and sometimes these can get so large it affects the airway. You might also see exophthalmos, the eye change in the eyes. And anyone that has hyperthyroidism is at risk for thyroid storm. So be aware of the symptoms of thyroid storm, and these symptoms you would want to report immediately to the healthcare provider. How do we treat hyperthyroidism? Some medications you need to be familiar with. Often one of the first things they try are PTU and Tapazole. Those don't cure hyperthyroidism, but they decrease the synthesis of T4. And sometimes by having patients on this for up to a year or 15 months, their body will just naturally go into spontaneous remission if it's an autoimmune process. In the meantime, they might also be placed on beta blockers for symptomatic treatment of that tachycardia that goes along with the increased metabolism. If they don't go into spontaneous remission, then they might be given radioactive iodine, which just goes to the thyroid and kills basically thyroid tissue. Not very specific. We don't know how much thyroid tissue will be killed, but that can lead to hypothyroidism. But patients who are pregnant or could be pregnant or trying to get pregnant should not undergo this procedure. Those patients would probably go immediately for a thyroidectomy, or also patients, like I said, that have extreme goiters that are affecting their airway, or cardiac complications because of that increased metabolism. Before patients go in for a thyroidectomy, they usually receive iodine. This is just plain iodine. That's going to decrease the vascularity of the thyroid, reduce the risk of hemorrhaging during surgery. So do know some pre-op teaching that you're going to be doing. Do know what you would have in the room in anticipation of a patient coming back from thyroid surgery, especially, a trach kit in case they do have an airway, ineffective airway. Do know the complications that can occur after having a thyroid surgery, especially if those parathyroid glands are removed inadvertently. They can develop hypocalcemia, so know the symptoms of that. Know your basic post-op care of a patient that has the incision there on the neck. On the other hand, hypothyroidism is slowing of the body processes, decreased metabolism, so everything is slower. And anybody who has hypothyroidism can potentially develop severe slowing of the body processes, and that is called myxedema coma. Know what symptoms would indicate that that's occurring, and know what can precipitate that. And as a nurse, we need to consider that anytime we give a patient with hypothyroidism a narcotic or a benzodiazepine or anything that further slows the body can trigger myxedema coma. And as you know, with hypothyroidism, you're going to have decreased T4, decreased thyroid hormone in the bloodstream. And when that is decreased, the TSH level will be increased, if it's a problem in the thyroid, because the brain is going to be saying um, to the thyroid, come on, we need more thyroid hormone. Now, sometimes hypothyroidism can be actually a defect further up in the HP axis. Excuse me. But if it's a thyroid issue, that TSH will be elevated. Once someone is diagnosed with hypothyroidism, they need to be on Synthroid for the rest of their life. It starts out slow and increases gradually. Anyone that is receiving Synthroid can potentially move on the continuum up into hyperthyroidism. Excuse me. So you want to be monitoring for symptoms of hyperthyroidism. And also be aware that because a patient who is receiving Synthroid, their metabolism will be slowly increasing, this can cause chest pain, angina, and dysrhythmias as the increase for oxygen, the demand for oxygen increases. And last but not least, just want to mention, as we talked about, especially with patients with had thyroid surgery, can end up with hypoparathyroidism if those parathyroid glands are removed. As you remember, parathyroid glands are affected by the PTH hormone, or release the PTH hormone. If you don't have enough PTH, that's going to affect your calcium levels. Calcium levels have the inverse relationship with phosphorus, as we talked about during our electrolyte lecture. So anyone that has hypoparathyroidism will pretty much have symptoms of hypocalcemia. You're going to be treating with IV calcium and oral calcium supplements. Hyperparathyroidism is not that common. It can be related to a parathyroid tumor, and their symptoms are going to be related to hypercalcemia. Oh, and I do want to mention one more thing on the growth hormone excess, or hypopituitarism, which is related to your anterior pituitary. This grid has kind of the basic stuff that we need to know at this level. With too much growth hormone, you're going to see growth in adults, and that is unusual. And these patients would also be candidates for this transsphenoidal hypophysectomy. There is some post-op care that's listed here for that. And those are the basic need-to-know concepts for the endocrine unit.